So, assalamu alaikum, everyone. I can see the audience, and I was told that there is a live broadcasting, but مباشر كذلك على Twitter on Twitter platform. So, hi everyone on every platform. Thank you for joining us in this really interesting webinar that is going to talk about the universal health coverage. Let me in the beginning extend my thanks to the Riyadh Economic Forum, who's hosting us, and together with the T20, Think 20 from the G20, which is one of the engagement groups, for co-hosting this event and for all the sponsoring and supporting organizations. Thank you so much for giving us this opportunity and the speakers to speak about the policy brief that they have worked on and presented to the G20. This webinar, as I have said in the beginning, is going to discuss the universal health coverage, which is, I am sure that a lot of you knows that the universal health coverage is one of the most important pillars of the Sustainable Development Goals that the United Nations is working on. And also, hence, it is one of the most important goals that the G20 is focusing on. The G20 is working on mainstreams, and they are also working with engagement groups. They have a number of engagement groups, and the Think 20 is one of these engagement groups, and it has a number of task forces. Task Force 7, which is led by Dr. Sami Swalem, who is with us on this webinar. Hi, Dr. Sami is also leading the Task Force 7 that is responsible for the SDGs and joining us in the universal health coverage discussion today, as it is under this task force. Just to give you a brief of what the Think 20 is, Think 20 is an international network of research groups and think tanks that usually come together in order to inform the decision-making process by not only the G20 leaders, but also, beyond the G20 countries, to inform their decision and base it and help them to base whatever decisions and recommendations they come with on evidence. So let us start this webinar then, which is again focusing on accelerating the progress towards universal health coverage. We will start with Dr. Sami Swalem. Dr. Sami Swalem, as I have indicated in the beginning, he is co-chairing the Task Force 7. Dr. Sami Swalem is currently the Director General of Islamic Research and Training Institute in the Islamic Development Bank in Jeddah, Saudi Arabia. Dr. Sami is also a member in several professional committees. One of them is the Technical Commission for the Islamic Financial Services Board. He obtained his master's from the Southern Illinois University in 1990 and his PhD in 1995 from Washington University. He co-authored a number of books and published several pages in Islamic economics and finance. So please welcome with me Dr. Sami Swalem. And also, if you just, Dr. Sami, before giving you the floor, let me just introduce the speakers of this paper. Dr. Hanan Lahmadi, who is a member of the Shura Council. I'm sure you know that she's a familiar face to many of you. Also, we do have Dr. John T. Rowland, who is an independent health system consultant. And we do have also Hussein Reka, who is an Asia Global Fellow at the Asia Global Institute at the University of Hong Kong. And lastly, we do have Dr. Ahmed Al-Amri, who is a senior consultant and an expert in innovation and strategy. So welcome, speakers. And let me go back to Dr. Sami Swalem, the co-chair of Task Force 7, to give us a brief about how does economists like you, Dr. Sami, sees healthcare as a public good, and how do we align healthcare with, from an economic perspective, with the quality of the healthcare services that we as healthcare professionals care about. Thank you so much, Dr. Sami, for joining us. The floor is yours.
Thank you very much, Dr. Tagreed. Can you hear me well?
Yes.
Good. I'm honored to participate in this forum. It gives me a great pleasure to join the esteemed panel. Economists are not very popular, particularly after the global financial crisis. I'm not sure if health practitioners will be happy to listen to an economist, but at least maybe I can change the perception a little, not too much, but a little. Now, what is unique about, or what is important about this crisis, the COVID-19 crisis, is that it shows there are certain goods or services that must be provided by the society collectively. They are not subject to market forces. And healthcare is on the top of the list. Also on the top of the list as well is defense, for example, and security, safety, order. All these society level services or society level goods, they have to be collectively provided and they cannot be subject to market forces. These goods are called public good because they are indivisible. We cannot split it, and whoever wants to take it, he can take it, and whoever doesn't want to take it, he can just leave it. It's just like order. For example, take traffic rules, for example. We cannot say those who want to respect traffic rule, they can do. Those who do not like to respect traffic rules, they don't have to. What would happen? There will be chaos because some people will stop when it is red and some people will just keep moving, and then it will be chaos. It cannot work this way. Everyone must respect the traffic rules, or else we are all facing a huge chaos. Same thing for healthcare, particularly when it comes to things like the pandemic and infectious diseases. Either we are all healthy, or we are all facing great risks associated or related to the pandemic or to the disease. So it doesn't. It is not that if you like it, you take it. You don't like it, you leave it. No, it doesn't work this way. Either we are all in or not. These are indivisible goods and services, and therefore we all must be in. We are all in the same boat, so to speak. Now, if they are indivisible, that means they are not subject to market forces, because market forces work well for divisible goods. If you like ice cream, you can buy ice cream. You don't like ice cream, you don't buy ice cream. If you are rich, you buy Tesla. If you are not so rich, you buy whatever car you like, and so on. That's fine. But when it comes to, these are divisible goods, and therefore they are subject to market forces. Public goods are not, and therefore that's where the non-profit sector comes in. Markets discriminate among people based on their wealth and purchasing power, but the virus does not discriminate between people according to their wealth. The virus will not say, give me your bank account if so that I can decide whether to invade your body or not. The virus doesn't care how much you have in your bank account. So it doesn't discriminate based on wealth. So if the rich is able to pay for treatment, what the poor cannot pay, then the rich will be affected, because this is a pandemic, it's an infectious disease, and therefore ultimately the rich will be in a worse situation. So it makes sense from an economic point of view that the rich would pay in order to treat the poor. So it does make an economic sense to donate, to have charity organizations that would help the poor, because ultimately everyone will be better off, and therefore the whole society will be better off. Economically, it makes sense, but public goods do not follow the logic of markets. So the economy is larger and wider and more broader than the market. market or for-profit sector is only one part of the economy, but we do have the non-market or the non-commercial or non-profit domain. Now, this domain contains so many players, including the government, but it doesn't have to be all by the government. It could be by a third sector, so to speak, who could participate in offering and providing these services to the society. And that's where moral values come to play. Moral values would coordinate and harmonize the for-profit domain with the non-profit domain. We need both domains. It's not that either this or that. I mean, communism and capitalism thinks that it's always a war. Either the non-profit domain has to dominate or the for-profit domain has to dominate. Well, it's neither. From an Islamic economic point of view, we have to have these two domains in harmony, just like two wings of the bird. The bird cannot fly without two wings. The two wings must function normally and in harmony in order for the bird to take off. Same thing for the economy. For the economy to function smoothly and productively, we have to have harmony between these two domains. So I conclude by just summarizing the main point is that that's why we need universal healthcare. We need universal healthcare because this is a social good or a public good that has to be offered collectively. We are all in the same boat, and that's why it is very important that we all cooperate and coordinate in order to provide this good to all members of the society. Thank you very much.
Thank you very much, Dr. Sami. This is really, comforting, to be honest with you, for this, for people like the speakers and I'm sure the audience who are, who care about universal healthcare, because indeed, providing health services for all, and then specifically with the minimum amount of cost, of course. And we cannot really, we have to create equilibrium between how much we're spending on healthcare and the quality of the healthcare services we're providing to society. Dr. Hanan Al-Ahmadi, I'm sure will take us through the challenges and the opportunities and what is universal health coverage. And I'm sure she will reflect on what we have heard from Dr. Sami. But allow me, Dr. Hanan, before you start, I just want to tell everyone that the questions are open. You can ask your questions. There is, a window for you to post your questions, and I will convey it to the speakers for them in order for them to answer your questions. Again, as I told you, as I just introduced Dr. Hanan is a member of the Shura Council. She's a leading researcher and member of the Board of Trustees of Riyadh Economic Forum since 2012, and thank you so much again, Dr. Hanan, as being a member of this forum to bring us all together here. She is also the former Director General of the Women Branch of the Institute of Public Administration, IPA, from 2009 until 2013. Dr. Hanan got her doctorate in Public Health and Healthcare Services Administration from the University of Pittsburgh, USA, and master's degree in Health Services Administration from Tulane University, USA. It's a great pleasure, Dr. Hanan, to have you leading this discussion. So please, the floor is yours, and please reflect on Dr. Sami, on what we have heard from Dr. Sami. Thank you so much.
Thank you very much, Dr. Taghreed, and good afternoon, ladies and gentlemen. It's my honor and pleasure to be here with you today. Dr. Sami, I have an undergraduate degree in economics, and what you said today was really one of my favorite viewpoints of healthcare as a public good. And that's why this is the main reason why we, as a team, selected this subject, because we strongly believe in it. And the COVID-19 crisis has really enforced the importance of universal health coverage. And you cannot treat healthcare as any normal or any other good. And healthcare cannot be completely for profit. It has to be a collective effort and cooperation between the different sectors of society, and truly from an I'm not an expert in Islamic economy, but from an Islamic economic perspective, the one you presented, it is important for people, for the Islamic society, to collectively share and help each other. So this is why we strongly believe in the importance of universal health coverage, and society should be responsible for each other. And so let me explain to you part of the paper. We wanted to, in the beginning, to highlight the concepts, several concepts that relate to universal health coverage, and then explain some of the challenges and why until now we are still talking about universal health coverage. As you know, there is a global commitment to health for all since the announcement of the Human Rights Declaration in 1948. And this was reinforced again by the Alma-Ata Declaration in 1978. I don't know if you all remember Health for All by the year 2000. And the year 2000 came and left, and still we don't have health for all. And there is a wide spectrum of the disparities and the variations in access to healthcare throughout the world, in rich and in poor and in middle income countries, and especially certain segments of societies. The vulnerable segments of society are the most affected by lack of access. And of course, that's why we had the announcement by the United Nations in 2015 regarding Sustainable Development Goals. And the third goal was dealing with universal health coverage. So the world leaders reaffirmed their commitment to health for all. And again, last year in the summit of the G20, there was affirmation by the world community regarding universal health coverage. So in the next slide, I will explain to you some of the main aspects of universal health coverage in order to build a resilient health system that have the important features that support universal health coverage and support health security for nations and for individuals as well. We must have 4 characteristics or 4 features. The first is availability, which means that availability of all essential health services. And this does not mean necessarily only curative or only clinical services, but it also means population measures as well as public health measures, prevention, health education, as well as having primary healthcare as the central center driver for the health system. So availability means everybody has access to the essential services needed by society. The second feature is affordability. And this leads to what Dr. Sami was saying about the cost of healthcare. An important element of universal health coverage is financial protection, which means that ensuring the cost of care does not put people at risk of financial hardship. People should not face catastrophic health expenditure and should not be forced to choose between healthcare and other life necessities. And this the problem of people having to spend out of pocket for healthcare is also universal. It's in higher income and lower income countries alike. The third feature is quality of healthcare services. And quality to us means effectiveness, patient safety, and patient-centered care. Effectiveness means that care is achieving the targets and achieving the outcomes it's meant to achieve. Patient safety means that no patient is injured or harmed by receiving healthcare or within the healthcare system. And patient-centered means it's not enough only to just provide care, but this care has to be, the health system needs to be responsive. Care should be respecting the values and the needs and the preferences of the patient. So the patient should be at the center of the healthcare system. The fourth feature is equity, and it's very important also in universal health coverage. And it was highlighted within the COVID-19 crisis. We've seen disparities in even the richest countries, the strongest countries. We've seen disparities in the level of access to healthcare all over the world. So universal health coverage means health for all, without discrimination and leaving no one behind. Everyone and everywhere should have the right to receive care, and no one should be forced, as I said before, to choose between healthcare and other life necessities. So in the next slide, I will be talking about governance and measurement of universal health coverage. As you all know, you cannot have what you cannot measure. So governance is very important. It's not enough. And as we've seen before, for the past 70 years, we were talking too much about health for all and universal health coverage. But if you do not measure it, if you don't have indicators and you don't have a framework to measure your steps towards achieving universal health coverage, you will not achieve it, you will not reach it. So therefore, it's important to have a governing system strictly in place because, and we've seen this everywhere in so many societies, poor governance, mismanagement of funds, and corruption. You know, mismanagement to me is just as bad as corruption, really, because we have very scarce resources. So if we just waste them and we misuse them and misallocate them, then we are losing very valuable assets. Lack of transparency and accountability, it's also one of the problems. Therefore, we need to have a strong system of monitoring and evaluation to promote accountability and effectively pursue universal health coverage. And we should select indicators and link the indicators with policies and have an information system that really supports our policies. And my colleague Hussein will be talking later about technology and information systems and their role in supporting the health system. In the SDGs, the Sustainable Development Goals, there are two indicators to measure universal health coverage. The first is dealing with coverage of services, and the other deals with the when we talked about financial hardship and financial protection, the proportion of of a population that has to pay out of pocket to health services. And if we see, this has been measured. If you see in the next graph, that shows, this graph shows you the, next please, shows the number of people having to pay out of pocket and have to pay more than 10% out of their pocket. So it's estimated that 926 million people around the world, almost 13% of the world population, spend at least 10% of their household budget on healthcare, and in some instances more. In fact, there are 100 million people around the world who are pushed into extreme poverty due to health expenditure. So escalating healthcare costs are one of the challenges and that prevent achievement of universal health coverage. The second indicator in the next slide is is coverage of healthcare. How much of the world population is covered with, has access to healthcare, and we see that at least half of the world population is unable to obtain essential health services. Half of the world population cannot obtain essential health services. There is an index that measures that. It's called the Universal Health Coverage Index, which has a value globally of 64 out of 100. And that is quite low. And it's an average, but it ranges from 22 as that is very low to the highest of 86 across different world countries. Of course, the highest regions are Eastern Asia, Northern America, and Europe. And the lowest regions in access are Sub-Saharan Africa and Southeast Asia. If you look at the next slide, you will see that, yeah, I don't want to have a very grim picture. Overall, our health status is much better than before. Our life expectancy is much higher than before all over the world. And our health systems and health advances are improving. But we are still struggling and we are still way from having complete access to healthcare. Therefore, we have in our paper diagnosed the main challenges. So we have 4 challenges in the next slide. The first one is financial sustainability, and we have discussed that. Raising the fund, having them being sustainable, allocating the funds, and using them efficiently. And I think my colleague Jonty will be talking about the financing needed for universal health coverage. The second challenge is the traditional fragmented models of care. There are more hospital-centered models of care that they give more words to primary healthcare than they actually support primary healthcare. So we need to bring back primary care into the center of a completely integrated healthcare system. And my colleague, Dr. Ahmed Al-Amri, will be talking about models of care and the different alternatives that we are proposing. The third challenge is, of course, the shortage of the health workforce and the predicted shortage around the world, expected to be 17 million health workers by the year 2030. And of course, this shortage is unevenly distributed between countries. So it is very severe in some parts of the world and less than that in other parts of the world. And it's not only in numbers, but also skill-wise. And also my colleague Jonty will be talking about the different proposals we have for the health workforce. Finally, the last challenge is limited utilization of innovation and technology. And we've seen in the COVID crisis how much implementing and going back to a different digital healthcare, how much it improved access. So we have many challenges in that regard. So we really need to tackle these challenges. And my colleague, Dr. Ahmed Al-Amri, will be talking about innovation, and Hussein will be talking about technology. So I think I will stop at that. And thank you, Dr. Tagreed, and hope to listen for the solutions from my colleagues. Thank you.
Thank you so much, Dr. Hanan. I can see the questions coming up for you and Dr. Suwailem, and I can't wait for the Q&A session to come, because I think people are having burning questions when it comes to universal healthcare. Well, Dr. Hanan, I agree with you that when it comes to universal healthcare, it's just like any other issue. We do have challenges, but with the challenges come opportunities. And one of the challenges also that you have highlighted so many times during the slides that you have presented to us is the financial and the workforce challenge. And it would be very interesting for us and for the audience to hear from you, Dr. Jonty, about this angle and how to look at the universal health coverage from a financial and from a workforce perspective. Dr. Jonty, as I have said in the beginning, is an independent consultant in health system and universal health coverage to governments. He's a formerly director of universal health coverage for KPMG. He's experienced in working in more than 25 countries, and I think this is really a great addition for us in this in this webinar. Dr. Jonty also has publishing award-winning research on areas including health system design and health economics and frugal innovation. So the floor is yours, Dr. Jonty, to talk and take us through the challenges and the opportunities of the workforce and financing when it comes to universal health coverage. Please go ahead.
Thank you, Dr. Tagreed, and good day, everyone. So we began our response to the 4 challenges which Dr. Hanan outlined by focusing on the 2 most fundamental, money and people. And as Dr. Hanan shared, we stand at this pivotal point in the story of this incredible ambition to reach UHC by 2030. We've a decade to go, and we're hit by this global event, which simultaneously proves beyond any shadow of a doubt the value of strong health systems as a public good, and yet which at the same time severely hinders many countries' ability to afford it. So how do we square this, opportunity for renewed investment in health systems and the challenge of actually raising the funds? And we propose 3 actions that countries should be working through right now as individual priorities, and one that we think the international community and the G20 collectively are best placed to address. So the first of our 3 individual actions that you can see on the first slide there starts by proposing that every health system leader right now, and they're busier than ever, but especially at the national and regional level, every health system leader right now should be developing their arguments and their evidence about the importance of health spending to economic growth and security. as the post-COVID recessions begin to bite in rich and poor countries alike, we can't see a return to austerity or a watering down of our ambitions for health for all. We simply don't have the time left. Health leaders need to go on the offensive now, politically, and I shared just one example on the slide here of a couple of years ago where a group of colleagues and myself at the outset of a major national health reform, universal health insurance for the Bahamas as it happens, built an economic model to demonstrate the future value of that policy to the country's economy, and showing a 5% increase in GDP as a result of improved coverage over a generation. And you can see on the next slide just some of the kind of key forces behind that health investment leading to a better economy, and that's improved labour productivity, reduced need for families to save for those catastrophic health expenditures, which Dr. Hanan mentioned, and therefore you can maybe spend some more in your own domestic economy, improve child health and educational attainment, and of course health security measures like resilience to shocks like pandemics. But we need to next think in the second recommendation for individual countries about where the money's coming from. And especially, I think, to capitalise on the intersectoral nature of the COVID response we're seeing now. Many more sectors now are understanding their role in supporting health and health systems. And those coalitions in many countries can be turned now. We have an opportunity into proposals to source additional funds for health in ways that bring simultaneally lots of agendas together. And you know, as I'm sure Dr. Sami is a lifelong devotee of health and healthcare, but we're seeing all sorts of leaders across finance and business, manufacturing, services even, now understanding the importance of health spending and a willingness to come on board with our agendas. And two of the strongest examples of these kind of intersectoral alliances are in the paper. One is sin taxes on unhealthy products, used to great effect very recently by the Philippines to finance their latest UHC expansion. And then also the redirection, the redeployment of fossil fuel subsidies, which the IMF have shown still exist in most major economies, are worth some $5 trillion a year, and are of course contributing indirectly to the looming threat of climate change to human health that many people are describing this COVID pandemic as the mere dress rehearsal for. And then finally, we need to think carefully about the prioritization of health spending, recognizing that there are going to be all sorts of demands on health systems to fill the gaps exposed by the COVID-19 pandemic. But we should not be like the foolish general always preparing for the last war. Rather, we have to equip our health systems to deal with the priority health threats for the coming decade. And that might be pandemics and PPE, but it's definitely going to be chronic disease, multimorbidity, and the health effects of climate change. Moving to the next slide, at the intergovernmental level, we seek to throw a renewed focus on the call from our colleagues from the last T20 for realignment and reform of the agencies governing and funding healthcare at the global level. As they kind of so powerfully demonstrated, and the slide's a little small here, but I encourage you to go and look at the original paper. This picture of global entities and funding flows still represents a really fragmented picture that doesn't reflect the strong message coming out of these agencies about a unified push on UHC. And so suffice to say that the interests of these different camps don't produce a picture that countries that depend on these agencies say will really nudge them towards UHC in the right way. And so the next slide, we come to the single greatest issue for the efficient use of health spending, which is the workforce. And in the human capital aspects of our paper, we discuss how virtually every health system is short on health workers and systematically training too few of them to improve their current levels of coverage and often even to sustain them. And as you can see from the quote there, the UN has projected that we need to see a doubling of the health workforce by 2030. And without blinding you with the numbers, suffice to say, we are nowhere near on track for that level of increase. And given that for some specialist types of doctor, it can take a decade or more to train them, it means essentially that some of these workers that we're going to have by 2030, the full complement of them are in training now. So once again, we decided to highlight a set of actions that countries individually should be taking and 2 proposals for things that can be done collectively to change the game. So for the 4 individual health system actions on the next slide, we draw out the areas that we thought showed the most promise for moving the dial on this issue within the context of a specific country. Firstly, obviously, to switch from under provision of health workers to, if anything, over provision of health workers on the basis that these are highly skilled professionals who, even if you don't have enough training places or jobs in your health system right now, they will find useful things to do in your health system, or maybe they will go abroad and provide remittances and other expertise and links to other global health networks. Secondly, to adopt the global kind of best practice emerging evidence in the use of new cadres of health workers. So this is physician's assistants, medical officers, community health workers, all these different types of workers that we're finding can actually do a lot of the work that doctors and nurses do, are quicker to train, less likely to leave, and free up doctors and nurses to work at the top of their license and really concentrate on the things that only doctors and nurses can do. Thirdly, to adopt better retention strategies, partly by pay, but partly by understanding in a more detailed and human-centered manner, what is it about their people's jobs that they enjoy, that give them job quality, and trying to focus more the job and role design around those things. And then finally, by treating patients and carers as a part of the healthcare workforce, which there are all sorts of examples now of countries doing. And finally, in terms of collective actions, we propose 2 things for bilateral and multilateral collaborations around human resources for health, particularly across the G20, which you have to remember has some of the biggest, as this slide shows, has some of the biggest importers of health workers and some of the biggest exporters of health workers. Firstly, the first proposal is essentially defensive to stem the unregulated flow of healthcare professionals from often low resource health systems to high resource ones, sometimes called brain drain, through a thorough renewal and review of the international regulations governing healthcare recruitment. There are international regulations governing healthcare recruitment, but if you speak to any of the companies that specialize in international recruitment of healthcare workers, they'll tell you that business is booming and that the existing rules are patchy, easy to circumvent, and frequently not adhered to anyway. So that's the first one. And the second one is that because this type of international migration will always find a way to happen when there's demand for it, and also because there's a huge amount that can actually be gained by international flows of health workers, so long as it's properly planned, we propose for bilateral partnerships to invest in certain countries as health worker export and training hubs, whereby countries with demand can invest in training quantity and quality in particular countries, and then agree to take a certain proportion of the workers that are produced by those institutions, whether physically or even as remote care workers, and then leave a certain proportion to stay in the country of origin. And there are examples of this in smaller ways between my own country, the UK, and India on nursing, and also the Philippines with many of its neighbours. But currently, these are not big enough for the coming levels of demand to surge in the next decade. And if there's going to be a global race for health talent, and if that race is going to increase, which it will, it's better to meet that in a planned way through these kind of partnerships than in a chaotic way. Now, as all sectors understand, technology and automation are central to releasing kind of human capability and capacity and human capital as well. So I'll turn now back to Dr. Tagreed to introduce my colleague Hussein to talk to you about those aspects.
Thank you so much. Thank you so much, Jonty. This is really interesting, and the question that I have been asking myself while listening, to you speaking about, these challenges that we're facing on achieving the financial sustainability. And by the way, when we say we see that we mean the globe, the whole countries. It's not about Saudi Arabia. We're talking globally. How can we achieve this financial sustainability and be able to really activate the solutions that you have mentioned to really work on the workforce issues that is being suffered globally. We usually go for and suggest always technology. Technology is, the way to go. Technology has helped us a lot in the pandemic. So are we putting the technology on a pedestal? Are we expecting much? How is technology going to help us accelerate achieving a universal health coverage? I'll leave this to Dr. Hussein Reka, who's with us today, in order to discuss, the universal health coverage within and how technology could help in achieving it. Hussein, as I have mentioned earlier, is a fellow at the Asia Global Institute. He has, in the past 12 years, been involved in several healthcare financing reform projects in the Gulf region. His main expertise are international health policy, health financing and insurance, and health economics. Also, co-authored several papers, and he has obtained degrees in health economics from University of York, and international health policy, London School of Economics, and is a qualified pharmacist. Thank you so much, Dr. Hussein, for joining us, and we cannot wait to hear from you how technology can help us solve the aggravations that Dr. Hanan, Dr. Suwailem, and also Dr. Janti has presented to us. Over to you, Doctor.
Thank you, Dr. Tagreed. I want to thank the Riyadh Economic Forum for giving us the opportunity to showcase today the findings of our policy brief, and the T20 Saudi Arabia, who give us the opportunity to contribute to such an important policy brief for such a noble cause as universal health coverage. Personally, as you mentioned, I worked a lot in my career in investing in universal health coverage systems. And as Jonty mentioned earlier, there's really great returns that I've seen in the region. So yes, technology. Everyone hopes and thinks that technology might be the silver bullet that might solve our problems, but it takes a lot of stuff on top of that. And I think technology is just an enabler. In this year's brief, we have put a special accent on technology as an important enabler for universal health coverage. And it was interesting because as we were discussing the main aspects, we had the pandemic evolving, and we just saw the developments happening, which showed technology playing really a great role. And we realized that this role will be even more important in the future in accelerating the efforts for universal health coverage. So here we look at ways how we or countries or the world, as you mentioned earlier, and all the different initiatives international level can contribute to universal health coverage agenda. But at the same time, we are identifying the challenges that we are facing with using technology to accelerate universal health coverage, because it's not easy, it's not a silver bullet. And we close by providing some key recommendations how to make best use of technology in the pursuit of universal health coverage. So as you can see in our overall structure of the brief, we are talking about several themes. And we discussed about healthcare financing, we talk about health workforce, model of care, data analytics, different partnerships. And these are basically the main areas that we are tackling, and main recommendations that came also from T20 Saudi Arabia statement on 30th of July to G20 countries. So as we were working on this joint research with the team, it became obvious that technology is emerging as an important key enabler for all these themes. There's sort of a linchpin that will connect all these elements into more efficient provision of these services, whether that's workforce, whether that's lower cost at a better value with different technology solutions. So Moving on to the examples that we saw around the world in around how technology has been used. Can move to the next slide, please. We found quite extraordinary examples of technology contribution, and these are really from very minor mobile technology, so spanning from digital technology to more sophisticated technologies like drones and artificial intelligence. So just few examples to mention, for example, the drones that are being used in Africa to cover remote areas to provide basic necessities and deliverables is a good example. You know how you can challenge and go with the remote spaces. Other examples are like the mobile health, the example that the initiative that WHO and ITU have come up with to push messages on awareness and understanding of the conditions of people. So for example, in Senegal, during the Ramadan time, there were these messages that were being pushed to people to raise awareness about diabetes and controlling their glucoses. But these examples are not only in sub-Saharan Africa, where we realize that really the index of universal health coverage is still low, and to get to a doubling down from 42 to 80 something, you really need to have something to leapfrog, and technology might help here in a way. But there are other countries as well, developed countries, like one example in digital health is Estonia, which managed to digitalize 99% of their health records. And this enables really not only to achieve the coverage, but also the data, the information to move with the patient and provide more holistic care to the patients at a situation when this potentially is a very safe way to store the data. And finally, this can translate also in the models of care, which Dr. Ahmed later on will tackle on, where technology helps even small clinics, like the example in Mexico, the sugar clinic, where the prevalence of diabetes is very high, the affordability is an issue, but then these clinics, thanks to the data and the artificial intelligence, they can fragment the population, create different archetypes based on which they will put some education, awareness, and personal treatment options around the patients, and to bring the cost to mere $150 to $200 per year as a subscription fee. So quite innovative things that wouldn't be possible in past decades or even 10 years ago if there was no new technology around. So in a nutshell, there's a really huge opportunity for a global reach where these new technologies can enable countries to rapidly progress towards universal health coverage, especially the countries with low UHC index at low cost, but with rapid reach. So moving on to the challenges. But yes, we admit and we recognize that there are challenges, of course, and even with technology, one has to be mindful of them. And the ones that we've identified are the challenges that we've identified are mainly, again, it keeps repeating, coming back governance. It became a topic of something that needs to be taken into serious account for universal health coverage. There's a need for governance and need of leadership at a global level to address these issues, not only from technology perspective, but in general for universal health coverage. But for technology specifically, the data confidentiality and ethical aspects of applying technology are pertinent. But there are other areas of challenges that we need to address. So affordability and accessible technology is one thing. The systemic approach to how we use research and development for technology in universal healthcare should also be tackled. And of course, the obvious two things is that you cannot use technology if there's limited infrastructure and workforce which is not prepared or trained or expertise to deal with these technologies. Having in mind and having identified these challenges, moving into the recommendations, we came up with a set of recommendations, a very sort of straightforward, direct recommendations, which should help to sustain the progress with the technology application in universal health coverage beyond what we see now with COVID pandemics. This has to be sustained. This is an opportunity for us to showcase that technology really can make a difference, and we need to maintain this pace and double down on these things with more initiatives and more investment, whether that's science, technology, engineering, and mathematics capabilities. But the challenges are there, and we need to address them. So data confidentiality is a major issue in privacy. So it's key to technology application and diffusion. So we are witnessing an increased appetite, I would even say thirst, for big data from big corporations for health data. Companies like Google, who would acquire a Fitbit for $2 billion, but not only because of the device, it's not very worthy, but it's because of the health data that they have. And then at the same time with the COVID, we've seen a level of intrusiveness from track and trace applications. So there needs to be some governance and confidence around these things to improve the trust of people around these solutions. Otherwise, we will face issues with the uptake, and we'll have a lot of laggards. So safeguards to maintain the confidentiality and privacy of individuals is a significant challenge, and regulators and policymakers should work in this direction. And this is where we need robust universal health coverage governance. Only for the reasons that we already mentioned. We need to sustain this technology uptake beyond the emergencies and with more initiatives. When it comes to ethics and empathy, patient safety, we mentioned automation. We have more and more artificial intelligence getting involved into diagnosing, and even moving even further to the future, some sort of treatment. We need to put some understanding around what is the ethics behind this. What happens if this diagnostic goes wrong? Who's responsible? Is it the algorithm behind it, or is it the institution or the physician? So there's lots of holes there that we need to fill the gaps. And then the empathy aspect as well. The health workforce is there to show empathy. So we need to be aware of this. And the penultimate aspect is patient safety. We have to be sure that patient safety is attained. We definitely want to say that there's no government on its own could achieve the scale of technology enough to achieve universal health coverage on its own. So partnerships with tech companies should be encouraged, subject to earlier mentioned privacy and confidentiality requirements. So yes, we want to have a win-win situation, but we need to safeguard the privacy and confidentiality just to maintain the trust in the population. Finally, and I think although at last, I think this is very important for the future, I think we need to empower the youth and provide tools to the next generations to translate these innovations and thinking and these new concepts into real-life solutions. And we've seen examples in Africa where these young kids come up with solutions how to wash hands for COVID, or some other very efficient but very low cost solutions. And the best thing that we could do for these young kids is to really educate them on science, technology, engineering, and mathematics, so they can translate these initiatives and concepts into more valid and sustainable and scalable products for universal coverage. So to conclude, we in this policy brief, we see technology as a major enabler for universal health coverage, and the whole world together needs to work smarter to harvest these technologies and sustain them in order to sustain these advancements in order to achieve progress with the pursuit to universal health coverage. Thank you.
Thank you so much, Hussein, for this really valuable information about the role of technology and really keeping our expectations up to the capabilities of technology, of what technology can provide to us in the healthcare. And I'm sure that whenever we speak about technology, innovation is comes in parallel with it, and that we need to, as you said, work smarter, but also to work smarter, we need to be innovative on the ways that we are suggesting, for people working in the healthcare in any healthcare system. What are the innovative ways that we can use in order to promote universal health coverage? And I'm sure that Dr. Ahmed Al-Amri will help us through this. Dr. Ahmed Al-Amri is going to talk about how innovation is going to help us really attain the goals of universal health coverage. Dr. Ahmed Al-Amri, as I also mentioned earlier, is a leading strategy and innovation expert whose experience spans more than 15 years in both public and private sectors between Canada and Saudi Arabia. Dr. Ahmed has also the Canadian board in neuroscience and studied in his MBA in the University of New Brunswick, Canada, and earned PMP designation, a project management professional from USA. Dr. Al-Amri was appointed as an academic professor in 2 Canadian universities and also for 4 years as a neuroscientist and a strategy modeling expert. He returned to Saudi Arabia in 2011, and since then he has been working as a C-level executive, and in 2014 was appointed as a CEO of publicly listed company in Saudi Arabia for 3 years. He has been serving as a board member, committee member, and advisor in different national and international institutions like the World Health Organizations. He's currently the founder and president of Innovation and Corporate Integration Company since mid-2017. Welcome on board, Dr. Ahmed, and the floor is yours also, like other colleagues, in order to talk about universal health coverage and how can innovation help us attain its goals, as I have referred earlier. Thank you so much. The floor is yours.
Thank you so much. Well, first of all, let me start off by, in December, 1st, 2019, I remember Dr. Hanan Al-Ahmadi called me and said, Riyadh Economic Forum is forming different teams, and they are going to apply for the abstracts, and the policy brief T20 is calling for. And since then, we started, forming the different team members and going through the different, studies that have looked at the subject of universal health coverage. And then I decided I will try to tackle the innovation and the different business models of healthcare. And I've been doing this for the past 10 to 12 years, talking about innovation business models. And honestly, when I talk about them, the word is a buzzword. It's interesting, but when it comes to implementation, it faces lots of challenges. However, as we were writing our policy brief, the COVID-19 kept going worse and worse. And one of the positive byproduct is that it made everybody attentive to the word innovation, and everybody now, and when I say everybody, I mean the population, I mean the policymakers as well as the executives and the different governments. They really want to apply innovation in its bigger perspective. Hussein have tackled the technology side, the digital side of the innovation. Now let me take you through what the innovation is in its very comprehensive meaning. And this I'm taking the definition from the G20 China 2016. And the G20 members agree that innovation is one of the key driving forces for global sustainable development, and it plays promoting the economic growth and supporting job creation, entrepreneurship, structural reform, enhancing productivity, competitiveness, and better services. The innovation perception usually is mixed up with other terms. One of them is research, one of them is invention, other is creativity. So let me define what innovation is. The innovation is very, very simple when it comes to definition. It is the implementation of an idea in a technology, product, or process that is new and creates value. So it is the implementation. It has to create value, and it could be technology, product, process, or a business model. There is a very clear connection between innovation and economic growth, and different studies have looked into the different variables that could link both, or at least indicate the link between both. And we found that the GDP, number of patents, a number of trademarks, the research and development, the foreign direct investment, the share of population with tertiary education and the total active population, unemployment rate, and exports are all different variables that links both the innovation and the economic growth. And we are not here to go through, how those link both together, but I just wanted to point out it. There is an innovation index formed of 5 main pillars: the patent applications, R&D spending as a percentage of GDP, days to start business, the logistic index, and the corruption perception. And it has shown that the higher the innovation index, the higher the GDP per capita. So those 2 slides just establishes as a start that the innovation leads to a better economic growth. And when it comes to types of innovation, there are, when you look at different schools, there are different types of innovation. However, I wanted to focus on healthcare and make it, very simple here. The types of innovation are 3. The consumer focused, and here we mean, how the services are delivered to the consumer. Technology focused, it has all the products and the processes by which we serve the customer. So this is technology focused. And the third type is the business model focused. And this is what I'm going to cover. Now, the models, when it comes to the models of care, there is an overwhelming evidence that countries that invest in primary care are better positioned to achieve health-related SDGs. And usually the strong primary care systems in the existing models seems to be, doesn't have the adequate attention nor the enough integration with the hospitals and the other levels of health systems. So the new integrated clusters should look like this. Everything is connected together, integrated. The patients who needs to be seen in the primary care should be there, and those who need to see secondary and tertiary care services should be served there as well. So this is the idea of the integrated clusters. Now, of course, we have the home care, the long-term care, but the whole model has to be integrated. What's happening now, and Dr. Hanan has mentioned it before in the first session, in the beginning of the session, that the current models of care are disintegrated, and there's not enough emphasis on the primary health care. However, primary care in isolation cannot deliver, the goal of the universal health coverage. So the new business models, like the one I've just shown you, are very important to really deliver the care to the patients. And another thing is that we should not only focus on the sick people, we really have to deliver the concept of health care. Sick people are, at any point in time, 5% of the population. So we really have to focus on how to prevent. So this will take us to the second concept that needs to be augmented, which is the self-care. Technology will help, connecting the self-care, which the person himself, will take the responsibility of connecting it to the integrated clusters. So the exchange between the two is very important in the success of the models of care. So the health will dramatically change. Currently, we have, as an approach, we have reactive care. In the future, we really have to focus on preventive care. The main location of service is the physician office. It has to really change to home, and more than 70% of the services can be presented to customers or to patients or to healthy people at homes. The distribution, we have now many providers. We really have to integrate them into few or one provider. And the data, and I think Hussein has covered this subject, but honestly, the how siloed the data is, scattered, disintegrated. We have to have the integrated data and there are many means to do this. Hussein has covered. So the innovations will impact the full journey, from the prevention to seeking stage, which is upon symptoms, to the care setting, diagnosis, clinical decision, treatment, and of course the enablers have to be affordability and systems level function. The issue here is that the innovation in healthcare is not easy because the forces that play a role in the innovation in healthcare are different. And here you can see that they are categorized into 6. The first one is the different stakeholders. Second would be the funding. Third is the policy. Fourth is the technology, and then we have the different customers, whether it was individuals or institutional, and the accountability. We all know that the medical treatments has made astonishing advances over the years, but the packaging and delivery of that treatment often inefficient, ineffective, or consumer unfriendly. Also, the cost continues to grow much faster than the economy, and so all those problems just beg for innovative solutions, including every aspect, as I mentioned, whether it was consumer focused, technology focused, or focusing on the different business models. Our paper have indicated that in order to promote innovation, we really have to target different levels, whether it was the different policies, putting a national innovation strategies, the innovation governance, where looking at it as a comprehensive concept, not only the technology, the ecosystems between the entrepreneurial ecosystems and the public ecosystems. We really have to merge and integrate them together. We really have to promote the small and medium enterprises, focused R&Ds, especially linking the innovations to universal health coverage, as well as the data availability. So these are the different levels that governments have to work at, and at the end, the prerequisites of the concept of comprehensive innovation, and not the technology only, include partnership to align private sectors and STEM skills to universal health coverage. We really have to have a strong UHC governance and policy direction in that field, the field of innovation, and definitely enabling regulations around privacy, safety, and ethics. And if you go through our policy brief, you will see that we have covered all of these aspects in more detail. So what I'll do, I will stop here and leave the floor for Dr. Tagreed to facilitate any questions we have from the audience. Thank you so much.
Thank you so much, Dr. Ahmed, for this, for the information that you have given us about not only how important innovation is important, which complemented what we have heard from Mr. Hussein, but also how can we overcome it, and why it is justified to really have innovation and technology under the eye of decision makers, and really look into the potentials that they are providing for us to achieve the goals of universal health coverage. Thank you so much, Dr. Ahmed, and thanks for all the speakers with us today. And I'm just, as I have told you, there are some speakers with burning questions that they're waiting for you to answer them. But I do have here, we do have here Dr. Abdulaziz with us, and I'm sure Dr. Abdulaziz would like to add to what the speakers are, what has talked about, or have any comment. Dr. Abdulaziz, are you with us?
نعم معكم. السلام عليكم ورحمة الله وبركاته. أنا عبد العزيز الشامخ. Thank you very much, Dr. Tagreed. And it's with a great pleasure to be with you here today with this great presenters and panelists. I've really heard what the presenters said and the distinguished speakers said about global coverage, healthcare global coverage, and I totally agree with what you have mentioned in your presentations. I agree with Dr. Sami that the role of private and public sector has to be defined. As you all know that the structure of healthcare in Saudi Arabia is completely different from any other country, where the government is providing like 60%, I mean the Ministry of Health providing 60% of the healthcare services to all population. And the other healthcare sectors like the Ministry of Defense, the Ministry of Interior, National Guard, and other healthcare sectors, university hospitals. The private sector presents like 30% of the healthcare in Saudi Arabia. Whereas, I mean, now we see that there is a high competition. For the last 30 years, we see high competition between the healthcare providers and the healthcare in public sectors, like between King Faisal, National Guard. That wasn't, I think, healthy at all, and we see the impact of that competition between. I totally agree with Dr. Hanan when you mentioned also your concerns about the healthcare system and health for all by year 2000. That's the slogan where we all heard about 1978 when it was launched. And unfortunately, we still see no health for all by 2020. If you look at the primary healthcare centers in Saudi Arabia, you cannot, it's below, way below the expectations, and where we believe that billions of dollars spent on the primary care and secondary and tertiary care, but still it's not as we would like to see it. Dr. Hanan mentioned also that yes, there is an improvement in healthcare where the life expectancy is high, where the infant mortality rate is low now. But at the other side, look at the obesity and diabetes. We are suffering from the society is almost 25% obese and diabetic, and that's really a challenge to the healthcare system. Dr. Jonty and Dr. Hussein talked about also the several issues and the technology. Dr. Ahmed also the innovation and technology. I remember when we introduced telemedicine and video conferencing. Can you hear me? Is it clear or?
Yes, we can hear you.
I remember when we introduced, and back in 1997, when I was with the Prince Sultan Foundation, where we introduced telemedicine program for King Faisal Specialist Hospital back in 1997, and it's been used since then.
You are not very old, Dr. Abdulaziz.
Oh, no, you are not, but I'm. So, 1997, the telemedicine and video conferencing was launched and presented at King Faisal Specialist Hospital, just to connect 5 major hospitals in the US with King Faisal for second opinion and also for educational purposes. But unfortunately, it wasn't really utilized properly, or even we invested a lot in that. These are the issues, and I would like to concentrate on stress on the speakers, I mean, just to come up with recommendations that can be implemented. Not, I mean, I don't like to see ourselves, I mean, repeating ourselves since 1978 until now, still we are just not achieving what we have. And I would like to see the primary healthcare issue in Saudi Arabia to be really improved, not the buildings itself, but also the manpower, the doctors, or nurses, I mean, the practitioners, where we see most of the doctors graduated from Saudi Arabia or internationally. They don't prefer to go to primary care because it's not up to their also expectations. So if you come up with a recommendation where the public health services provided by the Minister of Health, primary health care, and to stress on the partnership with the private sector, where we have the public-private partnership, and just working together and not to compete with each other. What we are seeing now that Ministry of Health is converting its hospitals to private, where they provide health care for people, fee for service. That means that everyone has to have medical insurance and go to either private or public services. The technology where the unified medical record for the last 25 years, I mean, and Dr. Hanan remembers, I mean, where at the IPA, the Institute of Public Administration, where there was an issue for them, and just a unified medical record number that will eliminate the misuse of the services, where people, they go from hospital to hospitals, from public hospital like Ministry of Defense to the Ministry of Health. They have like 10 or 20 medical record numbers. That's an issue. I would like to thank you all, and thank you for giving me the opportunity to just share with you this. Thank you.
Thank you so much for this beautiful reflection. And I'm not sure if one of the speakers have any addition or any reflection. Please, Dr. Hanan, go ahead.
Yes, thank you, Dr. Tagreed, and I would like to thank Dr. Abdelaziz Al-Shamikh. He's my ex-colleague at the Institute of Public Administration, and also he's my classmate at the University of Pittsburgh, and also he's my colleague at the Shura, used to be a colleague at the Shura Council. I agree with most of what he said. I'm very passionate about primary care, and I've done a lot of research on the journey of primary care in Saudi Arabia. I would say that we had a success story at the onset of primary care when it started. Having these primary care centers in the middle of the communities, trying to respect their values and traditions and understand their customs, and bringing care to them. Health education, the impact was huge to having primary care all over the kingdom. It was reflected on the immunization rate. It was reflected on maternal and child health. It was reflected on so many health indicators. So we were really going in the right direction. Somewhere in our journey, we lost track, like we have said in our paper, like what's happening in the rest of the world. Hospitals and tertiary care and specialized care are very attractive, and they're specifically attractive to physicians. Having this sub-specialization and specialized services and transplant and tumor centers and heart centers, all that is really very attractive and very professionally challenging. So many doctors like these specialties versus public health and primary care, and therefore primary care lost their image and importance, and slowly doctors were and the whole health system was shifting towards hospitals. Now we have a huge transformation project in the healthcare sector, and I think there are many positive aspects of that, and I see that they are reviving primary healthcare, and I hope, and I think we've heard before in one of the T20 presentations that primary care is going to be again in the center of the health system, we are still to see the whole picture of the transformation project. But I agree with Dr. Abdulaziz that we really need to revive primary care and allocate the resources needed to that sector. And of course, the rest of the comments, maybe my colleagues will address. Thank you.
If I may add, Dr. Tagreed, if you allow me. Now, when it comes to our policy brief, actually, we have, summarized our recommendations into three things, three set of recommendations when it comes to models of care, specifically the primary health care. First of all, we thought that increasing the capacity of the primary care is prerequisite to achieve better access and affordability. Second was that this should not be done by governments alone. A host of development partners must collaborate to ensure, stronger stewardship and coordination for the universal health coverage agenda. And also in the developed countries where, they have a strong family medicine, they have to focus on two things. Number one, to make the primary health care more patient-centric institutions. And the second, to strengthen the existing capacity within the health system. So this is just focusing on the primary healthcare. This is all what I had to add to this.
Thank you so much, Dr. Ahmed. And let me please ask Dr. Anavita if she has any other also reflections more than what Dr. Abdulaziz has illuminated on what the speakers have said. Dr. Anavita?
Yeah, thank you very much, Dr. Tagreed. And I really want to congratulate all the authors of this policy brief. It's a very, very comprehensive policy brief. And already with the Task Force 7 on SDG support to the G20 countries, this was universal healthcare is a critical subject. But with the coming of the COVID, as Dr. Hanan and Dr. Alamri have mentioned, this has become really seminal. And with the G20 being really the ideas bank for the G20, and while we are in the preparation now of a communique that puts together all these excellent recommendations, I think all the points that have been mentioned are critical. They are actionable and need to be actioned as early as possible. So I don't think I want to add any more on the comments because it has been a very, very comprehensive presentation. And I do know that there must be a lot of people waiting to ask questions from the speakers. But on behalf of the T20 also, I would really like to thank all the authors for this excellent policy brief that they've put together. Thank you.
Thank you so much, Dr. Anavita, and thank you so much for bringing COVID-19 to the discussion, because a number of the questions that we have received is talking about the potential of universal health coverage in order to encounter the pandemic and any future pandemics, God forbidden. But what is the role of universal? Are we still believing in universal health coverage? This is one question, one way or another that we have received. Another question has asked Dr. Suwailem, is universal health coverage economically justified because of all the benefits that we have, seen on the presentations of the speakers? I'll leave it to you, Dr. Suwailem, to answer this question. And then I want one of the speakers to answer about, is it still a good idea, the universal health coverage, when we, in times of pandemics, like the time that we're passing by? So Dr. Sami, please. Do you think it is economically justified?
Thank you very much. This is a very important question. Yes, it is justified, and we already have now two healthcare systems, the US system and the European system, and we can see the costs and the benefits of each system. It costs the American citizen. If you were following the American elections, you will have heard Bernie Sanders saying that you can buy insulin from Canada for a few dollars, while in the US it is in the hundreds of dollars. It's the same medicine, and it's only cross-border. Let me highlight just a few points why the market system will not help the health care system, services. These are essential goods that they call it price inelastic, which means people will spend on the basic needs regardless of the cost. You don't say, well, I'm going to treat my wound or I have to take antibiotics. If it is expensive, I will not take it. And if it is cheap, I will take it. No, if you are able to pay, you will pay no matter what. So the demand is inelastic, which means people are not sensitive to the price. And in this environment, sellers have every incentive to keep raising the prices because people will still buy as long as they are able to buy. They will still buy even if the price keeps going up. And that's what was happening in the US. The healthcare spending was growing in the past 20 years faster than the GDP itself. Another reason is that when demand is inelastic, there is no incentive to cut the costs and there is no incentive to cut the prices because demand is inelastic. Why to compete on the price? Just keep prices going up. And this is another reason why innovation did not find its way to the market. As Dr. Ahmed was mentioning, there is innovation, but there is no packaging of that innovation. Well, one reason is that if these companies are not subject to competition, why should they adopt innovation? There is no reason for that. But here is an important question, I think. If we want to avoid the market forces that would distort the services, but at the same time, we want to have a kind of healthy competition because, again, if it is all pure government bureaucratic process, there is no reason for improving the services. So this is where we can bring in the third sector. We can bring healthy competition among non-profit organizations to provide these health services. So the government, what would the government do is to set the stage, put regulations, governance, rules of governance, transparency, audit, and all these things, but then let the third sector compete. They do have incentives because even though they are not for profit, they still want to improve their images, collect more, even though they are not for profit, but they can still accumulate and expand their services and so on. So I think that's one way to promote competition, at the same time avoid the pillars of the market. Thank you.
Thank you so much, Doctor. And Dr. Hanan or Dr. Hussein, would you like to shed light on the universal health coverage in times of COVID-19 and pandemics? Dr. Hanan?
Yes, thank you for that question. It's very important. Most countries all over the world were struggling with COVID-19. But countries who had universal health coverage, they were better off relatively in terms of having a centralized system, a health system, where it's not a free market where people just go to the hospital and buy the service they want. Plus, this is a pandemic that the expenses were not known, the costs were not known. So countries that have a universal health system were able somewhat to manage, although some of them, they really struggled, but we are yet to compare. We are yet to see how did everybody fare, because we're having second waves in different countries. However, the countries that have a market kind of health system had to go back to be more centralized and to provide care free of charge, or provide adapt some government packages to cover for the services, for testing, for treatment, for so many things. So I think in the time of a pandemic, it was really highlighted that universal health coverage is quite important. Thank you.
Hussein, can you please, thank you so much, Dr. Hanan. And Hussein, could you please, shed light on how the universal health coverage from a technological angle has contributed, is really, reinforcing itself, especially in pandemics like the one that we're passing. So how does technology play the role and reinforce the need for universal health coverage?
I mean, yeah, definitely. Just a simple analysis to compare, Dr. Sami mentioned, when you compare European health systems and the American system, how they fared in response to COVID-19 is just one factor. And technology won't help you a lot if your system is not, if your system is fragmented. I mean, US is the most technology advanced country on earth, but it's a fragmented system. They're still struggling to put a track and trace system. There's no unified records. There's no medical records. So for me, the big lesson is, yes, universal health coverage needs to be doubled down, because the countries that really had some sort of universal health coverage and had a strong primary health care, coupled with strong hospital sector like Germany, they really fared very well, and now they're even more prepared. So definitely universal health coverage is needed, and we need to double down in the efforts because of situations like this. But we need to think about other regions, and I think we are very lucky. There's no major outbreak in Africa. Imagine if there was a major outbreak in Africa where you don't have a bare minimum health infrastructure, health workforce. There's no, or little universal health coverage. Although some countries are really putting a lot of efforts, the effects would have been devastating. And that tells us that we need to bring that as soon as possible, urgently, because these things might be very common in the future.
Exactly, especially that the heart of universal health coverage is primary health care. Allow me, Dr. Hussain, to move to Mr. Janti. And I see, a number of speakers asking, why can't we consider universal health coverage as a profitable business? Are we talking about, reducing the costs and not thinking about, the private sector coming into the game with the public sector and providing the services? Over to you.
I mean, the question was around whether healthcare can be profitable, and the answer is, well, in some countries yes, and in some countries no. The real question is should it be? And honestly, almost all countries are moving towards a mixed system now, where there are some public, some quasi-public, and some private providers. The question around is really around how you manage those private providers so that they are aligned to what the government wants to do with health coverage, and they're contributing to that agenda and not coming in at the sides and disrupting it by taking the doctors or cherry picking the patients or that sort of thing. So there is philosophically, very few countries seem to have much of an issue with providers making profit out of healthcare at this point, although funding, there is a very strong consensus should come from the public sector or directed by the government. The question is, what are you getting for that profit? What is the value that is provided by a particular private sector player? Because we don't just hire them because they're private. We have to hire them because they're able to provide some sort of value, or maybe they're able to provide services more efficiently. Maybe they're investing where the government can't. Maybe they're doing things that justify that 5 or 10 or 15% profit margin. So I think philosophically, very few countries have seem to have a problem with this now. And in fact, they're, as Dr. Sami said, trying to get their public providers to act more like private providers. But the question is, how good is the payer extracting value out of those private providers and making sure they're working for that profit margin?
Thank you so much, Dr. Janti. I think, this is also related to what Dr. Abdulaziz has mentioned earlier. Thank you so much. Dr. Ahmed, there is, a bombshell question for you about the technological innovations. And do you not think that technological innovations, once reinforced and, get entwined into the healthcare system, especially in a concept like universal health coverage, will lead to job losses? And then, it will, how is this going to fare against this idea?
Okay, well, this is an excellent question, and I think it needs a webinar by itself. However, I'll try to highlight, a few things. Number one, the healthcare as an industry has one of the oldest business models. It is really very, very old business model. It hasn't, been innovated or became more creative like the other industries. So it's lagging behind. Number two, as Dr. Sami said, this is inelastic. It's not the usual demand and supply. If you need it, you will look for it anywhere with anybody. The third is that being a labor intensive industry and moving into capital intensive industry by itself, I think is a good thing, because it will take us to the new kinds of business models that will actually make the healthcare more affordable, the access of care, the cost of care, and also the population health definitely better. When you look at the healthcare workers, maybe Jonty can also second me on this or have further comments. But when you look at the healthcare workers divided into different types, clinical and administrative. Now, the clinical, as I told you, the art of medicine, until now, the artificial intelligence is focusing mostly on data. Until now, they couldn't substitute the doctors. And I don't think in the near future we will be substituting the nurses, although there are, we can see robots that provide healthcare and stuff. However, losing the jobs, the classic jobs from one side will be substituted by new kinds of jobs in the future that I cannot even think of right now. But definitely it will evolve with time. But the most important, the priority here is that we really have to innovate in the business model, because this will lead to a better health for all. Now, what I'm afraid of is that the urgency that the COVID-19 has created and made everybody attentive to health and wants to really solve all the issues around the health, I'm afraid it will fade away with time, and they start focusing on other issues. So the thing here is, how can we maintain that attention to, as we have seen, health issue has stopped all aspects of life. So it's very important to address it early on. When it comes to the jobs, as I said, maybe Jonty also can talk about the workforce on that aspect.
Jonty, would you like to add something to this workforce, and thinking of universal health coverage, depending on technological innovations, could lead to job losses, could lead to, substitution of humans, of human capital?
Yeah, well, I share my colleague's vision for the kind of mostly beneficial, but some kind of risk aspects of technology and innovation. I think one of the workforce questions which is least asked about this question is, okay, so we're looking at doctors, we're looking at nurses, we're looking at other kinds of health professionals. Where are the managers and the administrators of health services and health providers and health insurance companies that are capable of leading this transition? And in some countries, we find that they have those people, but most countries I work in are short of that expertise. And I think that is a real aspect that all countries would do well to focus on, is developing the management and administrative capabilities to lead these kind of transitions in a way that is safe and effective.
Thank you so much, Jonty, for this. Yeah, I think it's a very important aspect to be, discussed in further discussions, to be honest with you. This needs a whole presentation by itself. But let me conclude, please, ladies and gentlemen, whether in the speakers or in the attendees, with this question that I would like to direct to Dr. Sami. Dr. Sami, we're now, this whole thing is happening with the G20, and one of the attendees has asked the question about, is there any way of providing a corporate governance for the universal health coverage, not on a country level, but also, globally? How can we make sure? I know that we have the Universal Health Coverage Index, and that countries are measuring, and that, there are people who are working on measuring how countries are doing when it comes to universal health coverage. But do you think that we can have corporate governance as a concept and apply it, to universal health coverage, whether on country level or globally? Over to you, Dr. Sami.
Of course we can, and of course we have to have governance for all sectors, not only for health. and for all kinds of health services, not only universal healthcare. So governance is important, but I suspect that, as mentioned by the speakers, since there are different systems of healthcare services in different countries, then the rules of governance will be tailored to these systems. But of course, it goes with, this is very obvious, I think.
Thank you so much, Dr. Sami, for attending to this question. It has been also a question, that I have had when Dr. Hanan was presenting, in the beginning about universal health coverage. Thank you also to Dr. Ahmed Al-Amri, to Dr. John T. Hussein. Thank you so much for joining us. And thanks also for the audience. And I'm sure that you will take the questions that, we have discussed together with the audience and take them into the paper and augment it with these discussions. Thank you so much to you, and thank you to the audience for attending this. Thank you very much, everyone.
Thank you.
Thank you.
If I might have your attention for just a minute now, I'm removing the hat as a researcher and presenter and putting the hat of Riyadh Economic Forum Board of Trustees. I would like on their behalf to thank you all for your participation and for your great work. And specifically, we want to thank you, Dr. Taghreed, for eloquently moderating this session, which was really not easy with so many speakers and so many questions. And it was great. You are the star of today. Thank you very much. Thank you, Dr. Sami, as our guest speaker today. And I would like to extend the thanks of Riyadh Economic Forum to the Secretariat of the T20, as they have been doing a great job during this very difficult year. And Saudi Arabia is leading the G20, and all the engagement groups are doing a great job. But the T20 was really able to fulfill its task and organize so many scientific events that I'm very honored, and I have to acknowledge their effort. And I would like to thank Dr. Fahad Turki for supporting Riyadh Economic Forum to conduct these webinars. And again, thank you all. Good
Thank
evening.
you so much, Dr. Hanan. Thank you all.
Okay.
Thank you so much.
Thank you. Ma salama.